So we're going to be moving next to our panel, our question and answer panel. So while all of our speakers are coming up and getting situated for our question and answer panel, Larry would like to challenge Dr. Holsinger to a push-up off for the Head and Neck Cancer Alliance Move-a-thon.
How about we do 10?
He's going to show you up. And he just had a hip replacement.
Because getting your body, oh my goodness, getting your body active so you can help your recovery for those that have already recovered, to sustain your recovery, and then of course to raise money. And there was a slight twist. There was a weird hiccup this year with the American Cancer Society. So we sort of morphed the Move-a-thon with push-ups. Now, it's not a traditional moving activity, but we have fine examples of push-ups here. So last year, Dr. Holsinger
I'm a cyclist, not a push-up guy. Okay.
was on a cycling trip, and for those that saw it, he almost got run over in supporting me, so I owe him.
The car was not that close.
Yeah, it was like, anyhow, so we're going to do push-ups. Anybody that would like to join is more than welcome. And please, wherever you want to do them, you want to come up here, you want to go.
There's a nice spot over there.
Oh,
There's
yeah.
a push-up corner. But who do we need to have up on? We need to create a maximum distraction so that no one watches this. Who are our panelists? Definitely come on up while Larry humiliates me. Okay, all right. Okay, we're doing this? Yeah, here we go. Oh, yeah, close. So we're doing 10, right? We're doing 10. Okay, here we go. Larry, you're going to lead it out. Okay, you want me to count? Let's go. 1,
2, 3, 4, 5, 6, 7, 8, 9, and 10. Way to go. They're not competitive at all. All right. Those of you who are speakers who are not up here on the stage, like Teresa, Danae, if you'd like to join us for question and answer. All right, so while we're getting our last couple of chairs, I think everybody on this stage will be familiar, with the exception of our fantastic chair gatherer, Dr. Gensheimer. Many of you may know Dr. Gensheimer is a radiation oncologist at the Stanford Cancer Center. Michael, thank you again for stepping in and representing the radiation oncology perspective. So we're going to go ahead and open it up for questions and answers. We have microphones in the audience, and we'll lead it off with Ron.
I'd like to congratulate this esteemed staff on the U.S. News and World Report #1 in ear, nose, and throat care. I think that's outstanding. That's great news.
Thank you.
Way to go. I'm still trying to absorb all the information that Dr. Holsinger just gave us up here, but I mean, the liquid biopsy sounds incredible. But in my mind, it's like we want to get the problem at stage 1, not when it's here. When it's here, it's already advanced. It's too late. So how do we do this liquid biopsy that we catch it at stage 1, and then you can do a surgery to take care of the stage 1, and then we're done? So I'm still not sure how this liquid biopsy fits into that protocol.
Well, right now we do not have a national screening. Right now we don't have a national screening program to identify these tumors. I think one day we will. I think the basis of that screening will be personal history, personal sexual history, family history, and then probably a blood test, whether it's the one I talked about or something different. My friend Eric Sturgis actually has such a screening test already underway in Houston, now ironically called Houston, although it's now called Trinity. And then those patients are being surveilled with routine nasal endoscopy, neck ultrasounds, and other tests in the anogenital area to identify these tumors as early as possible. In China, in what we used to call the Cantonese provinces of southeastern China, Epstein-Barr virus creates a very highly incident tumor called nasopharyngeal cancer, which some of you may have been treated for here. Yep. And there are routine screenings now done for EBV-related nasopharynx cancer, and I think we'll be doing the same in the U.S.
Thank you. Now, I just ask one other question. This whole thing about dormant HPV, again, it's, you get it when you're young, and somehow you don't clear it, then it becomes dormant for like 30 years. I mean, is there any test for dormant, or does the tumor actually have to appear before you can get the proteins and the DNA? I mean, when it's dormant, it's just not there. I'm still wrapping my head around that.
Dr. Feingersh has a PhD. I'm going to defer to him on that one.
Yeah, it's dormant in the sense that it integrates into the normal DNA and just sort of stays there. So it's not making enough copies of itself to really be detected yet. But potentially, outside of like actually just doing a biopsy and seeing if that DNA is there, I don't think that there's like a liquid test now that would detect it at a low enough level. But possibly one day we could have something that's like sensitive enough to do it, or even something where we, I have a friend who's actually working on a ultrasound guided nano RNA probe for HPV, where they actually tag the HPV RNA with a little nanoparticle that they can actually stimulate with ultrasound to bind to the HPV DNA that's in the cells. I mean, that stuff is probably like 10 years away, if I had to guess, but I mean, people are working on detecting really low levels of virus. But for now, we kind of have to rely on the tests we have, which need a certain threshold of DNA in the blood or in the saliva to be detected.
You're talking about DNA versus protein, because I thought basically you're trying to track the protein that the HPV throws off, but the DNA is also altered too, so you can test for either the protein or the DNA?
Yeah, the tests now, the blood tests measure the DNA, and then, there are tests that the pathologists do once the tumor is out where they measure certain proteins, not specifically the HPV proteins, but some of the other proteins that are associated with HPV cancers. Yeah, we're actually, probably the DNA is going to be the more sensitive thing to test. The DNA is the code for the protein. So the DNA is the first step,
Right.
and then the protein gets made when the virus is active and replicating.
Thank you so much. And again, this sounds very encouraging. I mean, stage one is where you want to get this stuff and nothing later. So I'll just stick with that. Thank you.
Yeah, just a follow-on point on that. I think the circulating tumor DNA stuff is super exciting. I think we still need to run the clinical trials to figure out how to incorporate this into clinical practice, though, because, for instance, thinking about clearance after treatment, we want to get every last cancer cell, right? We want to cure the cancer. And so would that last cancer cell make enough DNA to be detectable in the blood? Possibly not. And so it's really exciting, and we should run the clinical trials to see if we can de-intensify the treatment, even possibly, I hate to say it, potentially emit radiation, which as a radiation oncologist, I only want to give the radiation to people who really need it. But we need to test it in clinical trials because there's a long history in medicine of things that sounded extremely promising and then were tested in phase 3 large clinical trials and didn't end up working out as well as we hoped. So in the clinic, every day I have patients asking me, can we test the DNA level? Can we change the radiation dose based on it now? And my answer is usually the same. I mostly stick with the standard treatments. We get the levels. I think it's still helpful to see it, but we're still figuring out what to do with it.
Do we have any questions from our online folks? I'm going to try to alternate between the online and the not at the moment. Okay, all right, then we'll go along to Amy.
Yeah, so my question is specific in immunotherapy. And the reason I'm asking is when I was diagnosed with stage 4. Stage 4 nasopharyngeal cancer, and actually was halfway study at Singular University in NASA, where we had this medicine track called exponential medicine. So on the stage, their physicians are discussing the latest treatment or innovation in healthcare I gone do the most traditional treatment option. And one of our alumni friend connected me to the physician in Australia done very successful immunotherapy for nasopharyngeal cancer. I was talking to the doctors and I could not receive the treatment, obviously because there's the border country barriers, but then also like, I'm just kind of curious, and now 10 years after, like where are we at? Like, in terms of immunotherapy for head and neck cancer patients.
I don't see a medical oncologist on the panel who would be the ideal person to answer that. Yeah, I mean, it's already transformed care for people with distant metastatic disease, so cancer that's spread through the body. So many of those patients are getting immunotherapy now, and in a certain percentage of people, we're getting amazing responses. And the great thing about the immunotherapy is if it works, often you get a response for a long time, months to even many years, which is amazing. For people with earlier stage cancers, though, we're still figuring out how to use it. So we have active clinical trials where we're adding immunotherapy to radiation and chemotherapy. So we have the RTOG 1216 trial that's open here and that we're putting people on, where there's immunotherapy involved. The big drug companies have run some phase 3 trials of adding immunotherapy. So far, they haven't actually shown as much benefit as you might think. So it's turning out to be kind of complicated. It's not clear if while people are getting radiation, it's possible the radiation is counteracting the effects of the immunotherapy by killing some of the immune cells coming in, or the chemotherapy may be doing that. So we're not totally sure, but there have been some very large, high-profile trials that haven't been as positive as we might have thought, things like this Javelin trial. So still figuring it out.
My question is, in a group that I am a member of, there was one gentleman, I think he was treated up at UCSF, but I'm not positive about that. And the doctor there surgically moved his salivary glands up to a higher position such that when he was exposed to radiation, the impact would be minimized. That's the first time that any of us in that group or any since was treated that way. And I'm curious if you're familiar with that and if it has promise, and if so, why it's not done more often.
I think I can start. Yeah, the salivary gland transfer it's been around for like 15 years now. There's a little bit of controversy. The data is really good with it. It works very well. And but the kind of the flip side is that when you have good radiation oncologists like Dr. Gensheimer, they can actually dose the other submandibular gland in a way that it doesn't receive a lot of radiation. So there's some controversy as to whether that gland transfer is actually needed, because it kind of the modern radiation oncology is much more specific than when the studies were initially done like 10, 15 years ago.
If that was as true as your response would imply, then the swallowing side of the treatment plan wouldn't be constantly hearing dry mouth, dry mouth, dry mouth, I can't swallow, dry mouth. So I would say that the patient experience does not complement that answer.
It's only for like certain patients, like they have to have disease only on one side of the neck and be getting radiation electively on the other side, which usually they can do a better job of controlling kind of the field. So that would be
And so this, I think there's a Canadian surgeon in Alberta who really popularized this, and then it was presented multiple times to the NCI's cooperative group, and there just was a lack of interest. And we do have patient representatives, but we should always be listening to patient input about this. But I think surgeons are concerned about two things. We don't want to get into a neck where there might be metastasis, and we also don't want to perform a procedure that's not curative, delaying the start of treatment that is curative. And while complications are rare and delays due to those complications are extremely rare, I think from a kind of a Gestalt standpoint, it didn't sort of resonate with a lot of surgeons around the country. Although it's a cool procedure and and it may actually help. I think for the reasons that Dr. Feingersh mentioned and those that I just tried to articulate, I think it's sort of never really took off. And at the same time, we have IMRT and protons that will help make what the radiation therapist does so much better.
We have a question from an online participant, and this is more so for a survivor to answer if anybody can speak to this. This individual has speech changes, and they're wondering about their return to work and any guidance when people went kind of phased into work or went in full, and how they self-disclose their speech changes.
My speech, as you can tell from the larynx, and the prostheses, it went normal. I flowed back into my regular job 3 months after surgery. I didn't have any hesitations or any limitations. I just kept pushing forward. As far as them maybe having some kind of procedure done that they might have had complications with, maybe they're holding back a little bit. And I would say, don't push yourself forward, push yourself ahead. Don't hold yourself back from any kind of limitations. Try it. If it doesn't work, then you'll know automatically. But try, push yourself that extra. Always, always, because like I said, the only thing and the only person it's helping is yourself.
I'd love to hear if Teresa and Justin have anything to add to that from a clinical perspective.
I think it's always patient dependent. Different people have different timeline of healing, and then different people has different response to treatment. And I think for speech perspective, usually I always encourage my patients to practice speech functionally instead of on top of just doing the exercises that we gave them. I usually encourage them to go out to talk to people or to talk to people around them. And that helps them to feel first comfortable with their speech. Because sometimes they just feel like, oh, my speech is embarrassing. I don't want to talk. I don't want to go back to work. If I have meetings, I feel embarrassed. But I think the first thing is, work with your speech pathologist to work on your speech first, to improve the function, and then apply it to your just social and communication with people that you trust first. So always, I think before you go back to work, you wanted to practice your speech with your family and friends first, and then just gain that confidence first. And then even sometimes there's always some minor speech impairment. You may notice, you may feel like it's really significant, but other people may not. And then I think, again, I always encourage people, just educate other people at your work, in your environment, just to let them know that your speech is different, but you're trying and you're working hard. And then the more you get practice, the better you get. So I think my suggestion is, just be confident and be comfortable with your speech first with people around you, and then give yourself some time to practice before you go back to work.
Yeah, and I was just going to say that I think when you're recovering from head and neck cancer treatment, you're with you every day, and you don't necessarily notice the improvements that other people notice. And as I told you with my patient co-author on that paper, one of the great benefits that came out of participating in our co-design work was when it came to listening back to herself on the video and participating, she was really surprised at how good her speech actually was. But until she'd had the opportunity to get the biofeedback from participating in the project, she hadn't really appreciated how well she was doing. So I think you're with you every day, and as Teresa says, really good to check in with friends and people who maybe haven't seen you for a week or two to hear that, just get some feedback on those improvements.
Go ahead, Ron.
Yeah, I can try and answer the patient's question as well. I just can speak from my own experience, and my problem was, base of tongue. But during my protocol, I lost my voice for probably 2 to 3 weeks. I mean, I could not speak, very frustrating. My voice did come back, but it took a while. It probably took about 2 years before I felt the tone was really the same. And it seemed like it took my vocal cords a while to warm up when I was talking. I'd be at work and I'd be quiet for like 5, 10 minutes, and then the phone would ring, and then I would say hello. That hello did not sound very good. It was very croaky and not good. But then I started talking, and it seemed like the vocal cords warmed up a bit, and then I was able to sound okay. I mean, I knew it wasn't my voice still, but I knew that I was not croaking any longer. So I'll just add that. But yeah, if they lost their voice during protocol, I'm sure that signals as swollen vocal cords, and I'm sure that it would affect the vocal quality. Thank you.
Great, yeah. Yeah, you need the mic anyway because they can't hear you online otherwise.
So I had another push-up related, no, just kidding. So actually on the return to work topic, one of the things had talked with Dr. Gensheimer about in the past is being able to understand cognitive issues that may develop as a result of radiation or chemo or immunotherapy, and how to have a better understanding of that for people that may have experienced them and do need to go to return to work. So I don't think at the point we talked, which was like a year ago plus, there'd been any studies related to either, doing pre-cancer cognitive testing, post-cancer cognitive testing, or anything like that. So I was curious if that's a topic of interest to the community at this point, and if there's been any progress in that.
What aspects should we be studying of that? I mean, are most critical based on the experience we have here?
Sure. So I'll use me as an example. There was noticeable shrinkage in the hippocampus, as an example. And in the pure cognitive testing, let's call it the non-memory related portions, all tested, like let's go back proportionately to what my GRE or, graduate testing would have been. But my memory testing, short-term memory in particular, looked like a fraction of what it was previously. And then it's basically, we're now, 6 years out, just about. And the last cognitive testing I did was still in line with that. And part of it's just, I'm getting old, over the hill. But part of it has to be, in my opinion anyway, related to some of the side effects of the treatments that I had. So I think it'd be really valuable based on the amount of chemo brain, memory type issues that people have experienced post-treatment to have better data on that so people could make, appropriate return to work or other plans.
It was interesting. I was at a conference for VA Veterans Administration speech pathologists down in Florida last week, and they were talking about cognitive impairment post-COVID and mild traumatic brain injury. And I thought, this sounds just like the cognitive impairments that we see in people who've gone through chemotherapy and radiation therapy. And the interesting thing is they talk about how the testing often doesn't pick up the actual functional issues that people deal with in their day-to-day life. So the testing may not actually be as sensitive as we want it to be to really help tease out for folks like you who are having those struggles. But there was also big conversation about post-traumatic stress, because that's clearly a big issue in the VA. But I wonder, Danae, if you have any thoughts from a mindfulness perspective on strategies that might help people work through some of that to get that optimal function.
Well, yes, I do, Heather, but I also wanted to touch on Larry's point to offer 2 other metrics of consideration, which would be energy and sleep quality pre-treatment. So I just wanted to offer that. And in terms of the mindfulness piece, there is something that is heavily researched in the yoga world, and it's called Yoga Nidra. Nidra is the Sanskrit word for sleep. So you can think of it as yogic sleeping. And if you lay down and you listen, you reap the benefits. If you fall asleep, it's okay. You did it just fine. But the objective is to remain awake and alert, and you're guided through a series of visualizations. So it's very patient-friendly because you can do this practice on top of your bed. You need not lay down on the floor unless you are able to do so. So that's a practice. And that's my gift to the community. I don't know if the slide went up when I was speaking.
Yes, it was there.
It did, okay. So I have an audio recording, it's 29 minutes. May it serve you. But one more thing about the sleep and the energy piece, and we also brought this up in the support group one time. This is a cancer that, I don't know, I'm not good about math, but I can look in the audience and see it's highly impacted by the male population, right? But women, we met Nichelle, she's not here anymore. Women also suffer from this disease, and they come with their own challenges that are not also pre and post-treatment benchmarks, like menopause, for instance, and bone density were issues that were brought to the table in the support group meeting that I attended. So just piggybacking off what you said.
I was just going to say, one of my team at the Marsden occupational therapist is working a lot with not head and neck cancer patients, but people with chemotherapy. And I think at the other end of the scale, a lot of what's really important is helping people to have strategies and to understand what's going on, because I think quite often people aren't sure, that they just don't know what's happening to them and why they can't think and why they are feeling tired and are struggling to process. And so she runs groups for people to help them to understand what's happening. And it comes as quite a relief. Certainly when I've seen her talking to people, it's just a relief to know, oh, okay, this is actually to be expected, and there's a way out of this with a range of strategies. So I agree with you about, how do we identify people? But the flip side is as well, I think, is that understand, as it is with all of this, isn't it? If you've got good knowledge, good people guiding you and discussing things with you, that could be a great reassurance just to have the information going forward.
Something I'll take away from this discussion and Larry's question, unrelated to the push-ups, is that there's some preliminary phase 2 studies that evaluated the Fitbit, it could be an Aura ring that my family got me this year for the holidays, or an Apple Watch, and it does make me wonder if we should really be, distributing those and tracking sleep. It's amazing how badly I was sleeping until I had this. And so just, someone who's not dealing with cancer, it might be something that we explore that's very, objective to Heather's earlier point, because we have these instruments that can't measure true cognitive decline. Maybe we have something simple as sleep, we can do something about it.
And to make it accessible for everyone, to piggyback off our Dr. Megwalu's important, very important work that he shared about the disparities in health. So if Stanford was to step up for that it would be accessible, across all lines.
If only we were close to a bunch of technology companies.
If only.
They're all remote now, maybe.
It is true. They won't come back. It's not even for you.
All right, we're running close to the end of time, but do we have any other questions? Yeah.
Hi, one more. It was a real pleasure talking with Dr. Rowe. He gave me some great news about HPV vaccinations in England, that it's mandatory standard of care and that you basically have to opt out to not get the HPV vaccination. Whereas in our country, we're not there yet. Is there going to be a point where there's going to be enough statistics from England or from Australia that's like, yes, HPV vaccination's got to be standard of care, and let's do this, and you can opt out if you have some problems with it. But it's like we should be there. We should be there.
Yeah, and as I said to you earlier, it's been a long time coming because they were vaccinating girls as part of the programme. So just to be clear, it's now part of the vaccination programme, and as a parent who has to sign off the consent forms and everything, it's there. It's going to be given in school, and you have to say whether you're happy or not to have it. But there was a lot of campaigning that went on to get to that point to make sure that boys were given access to the HPV vaccine as well, and hopefully we'll see over the years the benefits of that materialising. So yeah, and it was lovely speaking with you as well.
All right, at that note, oh, you do have one more, good.
Basically, a little bit to piggyback on what you said, because, the routine preventive measures for women or there's natural HPV screening for every woman, pap smears. So I just am curious why it isn't more expansive and to include males, and, because when we do our routine yearly PAPs, we get an HPV screening. So why did we stop with women, or why isn't it more expansive?
Well, I mean, I think part of it, I mean, cervical cancer worldwide remains a significant public health challenge. We've reduced, I think the number of cases now, I looked this up in preparation of the talk, and it's only 13,000 cases a year in the United States, which is probably half the HPV-related oropharynx cancer. So now, throat cancer, head and neck cancer is the most common HPV-related cancer, but worldwide it still remains a significant problem. And I think it comes back to the fact that we don't really know how to screen yet. We don't know what all the, perhaps it's a blood test, perhaps it's a combination of blood test, endoscopic screening exam done once a year, and then a history, family history. So hopefully we'll be going there. And Dr. Feingersh is interested in expanding this conversation beyond just HPV, because wouldn't it be great if we could actually figure out a blood test to identify the HPV negative tumors that we see. And so I think that's one of his dream projects that he accomplishes between 1 and 2 a.m. He's working on that every day.
Great. All right. Well, we're right at 5 o'clock, so I'm going to go ahead and close us up. Thank you again, all of you who have come in person and the 130 some odd of you who joined us virtually today. I hope you all enjoyed the day. Please, you'll see a feedback form. Please feel free to give us feedback. We take it very seriously, and it helps us plan our events for next year. So hopefully we'll see you all back next year, and have a wonderful, safe day. And thank you again.